Hello, everybody. I'm going to say good afternoon for anybody who is LA or west of us. Good evening if you're over the ocean. If you're lucky enough to be in Hawaii right now, I guess it's still good morning for you. So welcome. I'm so excited to see how many people signed up to hear me talk about something that is super important to me and all the people that I work with. And just a little bit about me, in case you're wondering, like, who are you? Why are you doing this? So I'm a licensed clinical psychologist in the Southern California area, more specific, Torrance, if that makes sense. We're kind of near LA, kind of near Long Beach. I do neuropsychological assessments with kids, with adults, kids as young as 2, adults up to whatever age. I test pretty much for everything: learning, processing, ASD, ADHD, anxiety, mood, auditory, visual, you name it, dyslexia, dyspraxia, I do it all. I also do therapy with kids 12 and up, families with kids 12 and up, adults, and couples. Couples is also an area I really enjoy. Okay, let's get started. Okay, here we go. So I have titled this an overview of everything in 60 minutes. So my inclination would be to talk really fast, which thank you to Elizabeth, who reminded me in my, excuse me, East Coast upbringing not to talk so fast. So I'm going to try to talk slower today. The reason I wanted to call it an overview of everything in 60 minutes is what I tried to do with this talk is I wanted to include little bits of everything related to what I see going on with autism spectrum disorder. So we're not going to deep dive into any one particular area. We're going to sort of go wide, pull the net and try to talk about little bits of all different types of things related to it, thus, across the lifespan. We're going to talk about strengths, weaknesses, common misperceptions, common misdiagnoses. That one comes up a lot. Commonly occurring disorders. We're going to talk about why do you even care about a diagnosis or a label? A lot of people ask me, what happened to Asperger's? We're going to talk about what's the difference between autism, Asperger syndrome. We're going to talk about the difference between meeting criteria for eligibility for special ed in a school and a medical diagnosis of ASD or autism spectrum disorder. We're going to talk a little bit about how assessments might differ at different ages, right? Young children, school-age children, adults. Some non-typical presentations I want to get into. The ones I've chosen are ones that I see most frequently. And throughout, I'll be kind of weaving, challenges and interventions. All right, so let's start off. What is ASD? It's kind of a new term, new acronym you might not have heard before. It stands for Autism Spectrum Disorder. It's a neurodevelopmental disorder caused by changes in the brain during development. What that means is you cannot catch it. Way back in the olden times, they used to think, oh, it's related to how you were parented. Not true. It's a neurodevelopmental disorder. The trick with this one is symptoms typically manifest in early developmental period, which would be as a young child, prior to age 3. And what we're talking about are persistent deficits in social communication and social interaction is criteria A. Criteria B, restricted repetitive patterns of behavior, interests, or activities. However, in our official Diagnostic Statistical Manual of Disorders, if you go to page 57, where these criteria are printed, you're going to see a little note that says, but may not become fully manifest until social demands exceed limited capacities or may be masked by learned strategies later in life. And that's going to come into play when we're talking about some of the more atypical presentations. Now, before we get into this, I do want to do just a little bit of sort of housekeeping stuff. I think probably most people in here have heard someone say, I have dyslexia. And you've probably heard someone else say, I'm dyslexic. It's 2 ways of saying the same thing. And which one you choose is up to personal preference. We have the same thing when we're talking about a diagnosis of ASD or autism spectrum disorder. So some people I work with prefer, I have autism. Some people I work with will say, I'm autistic. We also will hear, I'm on the spectrum, or they're on the spectrum. And we also are now starting to hear people say, I have ASD. So usually what I do when I'm working with someone, individual or family, is I listen to what they use and I reflect that back at them. So when I'm talking today, you might notice I'm sort of jumping between those terms. It's just sort of recognizing and acknowledging that I like to reflect the way the person chooses to talk about it. All right, so let's go back to ASD. Okay, strengths-based. This is really important with the work we do at Summit Center is we're always coming from strengths-based. And all of these different things that we talk about, whether you've got ASD, ADHD, dyslexia, there are always strengths associated with them. And it's really nice to recognize that. So when we're talking about ASD, folks with ASD can possess advanced knowledge and skills. That can be really cool in terms of motivating someone to pursue an area of interest. They can have the ability to hyper-focus. It can be really helpful in jobs requiring attention to detail as well as meeting deadlines. They're known for having a logical mindset. This can really help with decision-making. And the last one, communicates honestly. This one I'm kind of thinking like, oh, maybe I should have put it on strengths and challenges. But in terms of communicating honestly, there are a lot of people that really appreciate this. There's no guessing involved. You know exactly what they're saying. Let's jump over to challenges. Okay, trouble grasping the big picture. When we were talking before, right, about being detail-oriented and the hyper-focus, sometimes you can get caught in the details, which can cause some delays. Sometimes with the adults I work with, I can see this in terms of team approach. Trouble reading between the lines. Open communication can work best. Social awkwardness. I think this one's probably the one that's most easy for us to understand looking, in from the outside, can contribute to anxiety when you're aware of it. So some of the people I work with are not as aware of the social awkwardness. It's more people around them, family members and friends. But when you're aware of it, that also increases the anxiety. Lack of social skills and social awareness, this can lead to misunderstandings on both sides, right? Both the person with ASD can misunderstand information coming in or even just observing a situation, and can also say things that can be misunderstood by the listener. Need for predictability. These folks may struggle with changes or when reality differs from expectations. And I really want to highlight the expectations because I feel like that can lead into and combine with the bottom one, which is sensory sensitivities. So a combination of sensory sensitivities and unmet expectations or different expectations can result in overwhelm, which I call meltdown. Maybe I should segue into that. I probably should have done a totally separate slide on that. A lot of times when we're talking about people with ASD, you might hear people refer to tantrums. Tantrum and meltdown are completely different. What you have when you have a tantrum is when you go someplace and you see someone, maybe a young child, could be an adult, and they're throwing what we call a tantrum because there's something they want and they're doing behavior to try to get that thing. This is really different than what I call an ASD meltdown, which is complete overwhelm. Could be related to sensory, it could be related to something new, unexpected changes, whatever it is. And often during an ASD meltdown, the person cannot even explain to you why they're having a meltdown. But when we go back and talk about it later, we're able to pinpoint all the different factors that led up to it. So I just want to throw that in there. Temper tantrum and meltdown are completely different. Okay, so remember earlier I said we're going to explain a little bit like where did Asperger's go? So back in 1980 is when they established autism as its own separate diagnosis. And that's when they described it as a pervasive developmental disorder. And the main parts of it were a lack of interest in people. And again, this is 1980s terms. We don't word it now this way. Severe impairments in communication and sort of unusual responses to things in the environment, and all developing the first 30 months of life. So then what we saw was later, in the later 80s, 87, they broadened the concept by adding a diagnosis on sort of the milder end, which I think some people, if you have kids that are older now, they might still have that original pervasive developmental disorder, whereas an adult, you might have been given that diagnosis as a child or younger person. Even though they weren't using the word spectrum at the time, the fact that they recognized a need to include something at the other end of the spectrum, of the extreme, was, again, that was introducing the idea of ASD being a spectrum. Autism spectrum disorder is not just yes or no checkbox, but it's a spectrum and you could kind of occur anywhere along the spectrum. So that was really a good thing. So it was the beginning of us sort of recognizing autism as not a single condition, but a spectrum of conditions that can present throughout life. It was kind of a way of, the original PDD was a way of including children who didn't fully meet criteria. And it's important to keep that in mind now because some of that folds into our atypical presentations. So let's fast forward now to 2013, that's when Asperger's disappeared, if you will. So, what they had done was in the mid 90s, they were further expanding the spectrum, right? And they sort of had autism on the bottom of the spectrum, more nonverbal, more self-stimulating behaviors. And at the upper end of the spectrum, they had this Asperger's disorder. These were folks that didn't have intellectual disability. There was no language impairment, and they gave it a different name. It was two separate things at that point. So in 2013, what they said was, these are actually the same disorder. They have the same difficulty with social communication, interpersonal relations. We see the same restricted, repetitive patterns of behaviors and sensitivities. Let's combine these. And then what you do is you just say, okay, so here's a diagnosis of ASD. And then you would specify with or without intellectual disability, with or without language impairment. And so, again, they're recognizing that they're the same. The one drawback to that is sometimes when I'm working with people, there's not a widespread recognition that those were combined. And so if I'm describing a child as, having autism spectrum disorder, people tune in on the word autism, and they're picturing that that child was at the lower end of the continuum, nonverbal, not as able to participate with the original intellectual disability intact. And so sometimes when I'm talking and I'm working with people in education and whatnot who maybe aren't as up on the changes, because I know you're like, oh, this is 2013. That's actually only 11 years ago. And so if it's not something you work with a lot, you might not be aware of it. So a lot of times when I'm talking about it, I'll say, ASD, Asperger's, autism spectrum disorder, just to make sure that I'm making people aware that I'm reinforcing that it's all been combined and it's all ASD now. Okay. So let's jump over. Let's get into some of our common misperceptions. So again, these are things that, and I'm not saying that they're not true. I'm just saying, when I'm saying ASD, Asperger's, autism spectrum disorder, if I get a group of people in the room together, this is something I like to do in a workshop format. I like to say, ASD, tell me what you're thinking, and the things that people will toss out. People think that, they all have trouble understanding sarcasm. They all have trouble with empathy. They have big vocabularies, but don't understand the words. Everyone thinks ABA works for everyone, that insight-oriented therapies won't work. Everybody rocks or self-stims. They don't process feelings. They can't connect dots. There's difficulty recognizing other people feel differently. They all have food issues. They all have sleep issues. They all don't have good or best friends. Everyone has poor eye contact, and everyone is nonverbal. So I'm hoping that anyone on here who knows someone with ASD, or if you have ASD yourself, in your head, you're like, no, that doesn't apply to everyone. Okay, let's jump over now to common misdiagnoses. I have to apologize on this slide. So I am not a Google savvy person, so my slides are in PowerPoint. And for some reason, this one would not translate. So it's very tiny, but all it is the names of disorders, and I'm going to read them to you. I'm not a slide reader, but I will read it just to make sure everyone can hear them and understand them, because they're very tiny. Okay, so the first one is bipolar. It's a common misdiagnosis. I will tell you, I see it more with people assigned female at birth as opposed to people assigned male at birth. It kind of, what you see is mood swings, agitation, sort of very anxious, rapid speech. And some folks with ASD will get misdiagnosed as bipolar. Borderline personality disorder, due to the nature of relationships. A lot of ASD folks can have trouble with relationships, either forming or maintaining relationships, understanding other people's points of view, and they'll get mislabeled as borderline, whereas borderline personality disorder is constant conflicts in relationships, all relationships across the board. The next one I know is a scary one. Schizophrenia, people see that one. They're like, oh my gosh. A lot of the different tests and measures that I use when they're sort of giving red flags for behaviors to look at will actually trigger the red flags for schizophrenia. And then when I'm presenting results, I present everything that I'm finding. If you're like, oh my gosh. So I just like to make people aware that some of the behaviors that are associated with schizophrenia will also be associated with ASD, and they'll trip the same little red flags on different measures that you do. The difference with this is that ASD folks can become fixated on ideas that are not necessarily conforming to social norms, sort of think about things differently. There can often be extreme fears, sort of like, unusual repetitive body movements and whatnot. The affect can be a little bit off. Conversational give and take can be a little bit wonky. And sometimes people will see that, and in combination with social withdrawal and some difficulty with emotional responses to other, will mislabel it as schizophrenia. So I feel like that's a really important one to highlight, because in the different measures I use, I feel like that's one where it often trips the same little red flags. Panic disorder. And that's because folks with ASD can often have what's considered a big reaction to something that other folks don't realize is that big. But in terms of the ASD person, it's because the reaction is to something unusual or unexpected. So flashback to earlier, remember we were talking about sensory sensitivities, expectations. So when those come into play, the response to something unusual or unexpected can be pretty big, and that gets misdiagnosed as panic disorder. Eating disorder. And a little bit later, one of the things we'll talk about also is sometimes what happens is people are picking up on different pieces of the ASD and they're like, oh, that's it. And they miss the ASD portion. This one definitely comes up. Folks will pick up on the eating, avoidant restrictive food intake disorder. We kind of smudged that down into ARFID. And people will pick up on that behavior, but because the person is masking or it's an atypical presentation or what have you, they'll get a diagnosis of maybe eating disorder and panic disorder, but the full-on ASD diagnosis will be missed. Some additional ones, ADHD. This is a really common one. And one of the reasons is that the behaviors that are in ADHD, difficulty with attention, executive function challenges, are also part of ASD. So often people will get misdiagnosed as just the ADHD, and people will not look further and notice, oh, there's also social challenges, some repetitive behaviors. This is actually ASD. SPD, this is sensory processing disorder. Adults who might have had this diagnosis as a child, or people that have older kids, you might have heard it called sensory integration disorder. And so sometimes I have actually quite a few people who've come in with a prior diagnosis of either sensory integration disorder or sensory processing disorder. And if you remember earlier when I showed you the criteria for ASD, criteria A is sort of all the social communication, social interpersonal stuff. Remember criteria B, the restrictive or repetitive behaviors or interests. The sensory stuff falls under there. So sometimes what's happening when I see someone who has a diagnosis of sensory integration disorder or sensory processing disorder is someone has picked up on criteria B but hasn't checked for criteria A, or the person's masking criteria A really well. OCD. Okay, this is another one where when you're doing, parent report measures, self-report measures with teens and young adults, the OCD red flags are often going off, and it's often ASD. Now, can you have OCD and ASD? OCD is obsessive compulsive disorder. Yes, of course you can have both of them. But I just always like to caution people, they can really look the same, especially on something like a behavioral measure where you're just checking boxes. So, really briefly, the difference, someone who has obsessive compulsive disorder, they're bothered by it. It's not pleasant. There are obsessive thoughts that keep coming back, and they then do a compulsive behavior in response to that thought. They often feel if they don't perform the behavior, it's a feeling as if something bad will happen. Whereas when we're talking about repetitive behaviors, some people, self-stimulation, self-stim, you might hear it shortened in folks with ASD. Those behaviors are often calming, enjoyable, if you will. A lot of the folks I work with that have ASD or on the spectrum do those behaviors when they're thinking. They'll be pacing because they're thinking about something. They're not unhappy. It's just what they do. The other way that I see them too is when anxiety goes up, behaviors that look like OCD and someone with ASD also go up. But that makes sense when you think about it. If they're behaviors that are done to calm and self-soothe, if my anxiety has gone up for some reason, those behaviors are going to go up. And the last one is social anxiety. Well, it's the last one on my page. There's a whole bunch on here. I'm so sorry. I can only get it on one slide, guys. Social anxiety. I think it's pretty clear to see where that one comes from. That one, it's almost like someone is picking up on criteria A for ASD, difficulty with social communication, interpersonal relations, and they're missing criteria B, right? Things related to sensory and repetitive behaviors. And so with that one, with this one, again, this is one I think is more common that I see with people assigned female at birth as opposed to male. This is also one that I'll see increase with time. So as demands change on people, social demands really change middle and high school as compared to elementary. All of a sudden, I will have an influx of people, predominantly those who identify as female, coming in the door, end of middle school, beginning of high school, with diagnoses of social anxiety disorder. You're probably thinking, can you have social anxiety disorder and NASD? Yes, you can. I mean, for all of these things, you can pretty much have both of them. Language disorder, selective mutism. So remember earlier we were talking about, in the olden days, a diagnosis of autism meant you also had a concurrent intellectual disability. You also had a language impairment. They were often nonverbal. That's not true today. Now it's a spectrum. We do still have folks that have language challenges, and we have lots of people who do not have language challenges. But sometimes what happens is someone will pick up on the language challenge and the difficulty with communication, instead of it being recognized as a difficulty with social communication, social processing, social skills, will get attributed solely to a language disorder. But yes, obviously you can have a language disorder with ASD. Selective mutism. Selective mutism is when a child is selectively mute, obviously. If they talk in some instances and not in others, it's really common for them to not talk, say, at school, or in a situation where they're feeling anxious, and then at home, maybe they're just fine. So I do see this with folks with autism spectrum disorders also. Generally, it's kids, but I do have it with some of the teens and young adults also. It's almost like a fight or flight response to an anxiety provoking situation where they'll just shut down and go mute and they can't say anything. So I've got a bunch of them kind of grouped together at the bottom here. I've got conduct disorder, oppositional defiant disorder, which everyone's heard of as ODD, that gets tossed around a lot. And then I have one I'm betting most of you haven't seen, which is DMDD. It's dysregulated mood depressive disorder. It's kind of a mouthful with that one. These three, I often get kids coming in the door where there's a prior diagnosis of this. They're often kids that have one of the more atypical presentations. And so the social processing challenges are getting picked up mistakenly as it's usually behavioral. Usually when someone comes in, they have a misdiagnosis of conduct disorder or ODD because so many people don't know about DMDD. So I just wanted to explain that. So conduct disorder and oppositional defiant is what they say they are. They are conduct disorders, problems with behavior. Can you have it with ASD? Yes, you can. And a child with ASD, often when they get older and they're put under so many more stressors, social, educational, executive functioning, there's actually research detailing that they can actually start to exhibit more behaviors that look like ODD as they get older. But again, think about what's happening if you're under severe stress, right? Social, emotional, academic stress, right? Executive functioning, working memory demands, right? As anxiety goes up, what do we see with untreated anxiety over time? It often results in depression. So a lot of times what I'm finding is that increase in behaviors of ODD as the child gets older is actually this DMDD, which is the depressive mood dysregulation disorder, which is a depressive disorder. It's not a conduct disorder, but it can look exactly like the other two. So you'll see a lot of behaviors, angry, disruptive, disobedient, arguing, stubborn, temper. It can really look quite similar. And so it's really important when you're having a child evaluated for this, that it's someone who understands the difference between behaviors that are coming from conduct and behaviors that are coming from depression, and how that all sort of tangles up with ASD. Elizabeth, do you want to make an announcement about questions, or do you want me to? Because I'm sort of seeing dings with hands going up.
Yeah, a couple of people have raised hands. There is a Q&A feature that we're going to be using, and Lisa's going to do the questions at the end. But if you look in the lower corner of your screen, there should be a triangle, square, circle icon. And if you click on that, you should see a Q&A, which will allow you to put in your question now, and then we'll actually read them, and Lisa will go over them at the end. That's the plan.
Thank you, Elizabeth. As we get towards the end, I'll put up a slide that actually shows you guys what the button looks like in case you're wondering. Some of us are not as familiar with Google Meet, including me. Okay, thank you, Elizabeth. All right. Yeah, sorry guys, if we were live format, I usually have people jump in, but we have so many people today that we decided to say 15 minutes at the end. Okay, let's jump over into commonly co-occurring disorders. And so a lot of these are going to look familiar because we just talked about them. So when we're talking about other things, you can have someone who's misdiagnosed as something, but they've missed the greater diagnosis of ASD. You can also have things that are concurrent. We have both of them. Or you can have the diagnosis of ASD and you can have something else with it, and we've missed that. So there's lots of different possibilities here. So what I've done here is these are the most commonly occurring disorders. So it's really common for me to see these together. Okay. I'm just going to ignore those for now. So commonly co-occurring disorders. So the avoidant restrictive food intake disorder. So again, the difficulties with eating. So when you're looking at these, you want to look at where the challenges are coming from, right? Is this something to do with limiting caloric intake, or is it more to do with sensory sensitivities and routine? Or we're trying to, parse apart where they're coming from. But can you have both? Yes, you can. Auditory processing disorder. This one comes up so often. Auditory processing disorder, and I don't think I mentioned this one before because this one is very rarely a misdiagnosis because I feel like a lot of people aren't up on it. Auditory processing is not your hearing. Auditory processing is what your brain does when the signals go through your inner ears. Think of it as your brain's interpretation of sensory stimuli. Think of it as information sharing between the two sides of the brain. So here's the tricky part of this. Someone that has an auditory processing disorder, yes, they might get misdiagnosed as having something, but it's not usually ASD. They're usually misdiagnosed as having ADHD. People think they're not paying attention. And so then we do some testing. We're like, oh, no, it's actually ASD. However, people with ASD often commonly have auditory processing disorders and ADHD. So there's kind of a package of things that go together. And this one is a tricky one because yes, it's part of the, notice it wasn't on my common misdiagnosis slide because it's not commonly misdiagnosed related to ASD. It gets misdiagnosed as ADHD. Visual processing disorder, again, very common for people with ASD to have concurrent visual processing disorder. You could think of it as how well your eyes and brain work together. It can impact things like reading, taking notes, writing, huge homework fatigue. Anxiety. So most recent research is from 42 to 79% of people who meet criteria for a diagnosis of ASD also meet criteria for a concurrent anxiety disorder. That's pretty big. ADHD, again, super common for people on the spectrum to have a concurrent ADHD diagnosis. However, I know some of you are probably thinking, oh, but earlier you said all the behaviors that are in ADHD are in ASD. Yes, I did. Do we always give both of them? Not necessarily. You see them to different degrees. So when we're talking about people with ASD, often what I see, it's not necessarily the attention, but I see more of the executive function. And so it's kind of more difficult to give a diagnosis of ADHD without some type of attention, since that's the main word in it. But the executive function stuff's really predominant. A lot of times people will focus in on the executive function part. They're like, oh, maybe it's ASD, and we go in and test, and we're trying to figure out whether it's ASD or ADHD, depending on what the attention symptoms are. But again, it's super common for people on the spectrum to also have ADHD. And if the symptoms are at a significant level where there's definitely impact, yes, you can definitely give both. Specific learning disorder. This means reading, writing, math. Specific learning disorder in reading would be dyslexia. Specific learning disorder in written expression would be dysgraphia. Specific learning disorder in math would be dyscalculia. So it's also really common for individuals on the spectrum to have specific learning disorders. Developmental coordination disorder. And this is a huge mouthful. And in the land of OTs, you might hear it called dyspraxia. This is people that have difficulty with the actual act of handwriting. So it's different than disorder of written expression, which is difficulty like responding to an essay or short answer prompt, getting information from your head onto the paper. This one is actually fine motor skills, the actual act of writing. And the last one, the sensory processing disorder. So, and you might be thinking, but that's just criteria B. Sometimes it's to an extent that it's more than criteria B, but an interesting thing about sensory processing disorder, which, remember, for people that have older kids or had the diagnosis as a child, if you're an adult now, you might have heard it called sensory integration disorder. It's a diagnosis we actually don't give over 12. It's only given in childhood. Okay. Why is a diagnosis important? I am not diagnosis happy. No one at Summit Center is diagnosis happy. However, sometimes it can be helpful. It means you can provide the right treatment. Let me give you an example. If you have someone who you think has ADHD and they actually have an auditory processing disorder, and I give them ADHD meds, it's not going to help because they have an auditory processing disorder, not ADHD. If I have someone who has DMDD, right, so that's depression based, and I'm treating it like poor behavior, negative behavior associated with a conduct disorder, and I'm not addressing the depressive symptoms at all, it's not going to help. So same with ASD, when we're giving an ASD diagnosis, we're recognizing all the components. We're recognizing that huge anxiety piece that's part of it. We're recognizing the social challenges. In many cases, we're recognizing some significant sensory needs, a need for a sensory diet. So a diagnosis is really important in terms of providing the right treatment. Another important thing to consider when we're talking about providing tools to teens, when we're talking about providing tools to teens and to young adults and to adults, people are more likely to accept the tools when they kind of know what they're for, right? So if we're just saying to an adolescent or a teen, oh, we're going to send you for this, peers social skills training class. Well, why would I do that? But if you explain, okay, well, you have this thing and this is what it means, and this is how it can impact you, and here's how this can help, people are more likely to utilize that tool. Access to services. Now, a lot of people that I work with that are on the spectrum don't necessarily need services because they're part of one of the unusual 3 atypical presentations, but a lot of folks do need services. And for people that are nonverbal and have intellectual disability, there are a whole lot of wonderful services that are available through, school district, regional center, state of California, and you can't access them without the magical medical diagnosis. So it can be really important. Another thing to think about too is if it's something where a child, say, needs speech and language services or whatnot. If there's an actual diagnosis, sometimes insurance will also kick in to help cover things like speech, OT. So that's also important. Okay, it can be protective. This one's probably going to sound the most surprising. But remember earlier when we were talking about things like, kids and teens that have an undiagnosed autism spectrum disorder, I often see them come in the door and they've been misdiagnosed as a conduct or behavioral disorder. But there's definitely consequences of that, right? So I've had some kids where things have happened, particularly at the high school level, where there were consequences because there had been no diagnosis given. And all of a sudden, when people understood, oh, wait a minute, like this was a complete misunderstanding stemming from the ASD, then it was a whole different ballpark. If anyone's ever read, I'm blanking on who the author is, but there was a series of books called The Rosie Project, and it was detailing, it's fictional, but it's an adult male's sort of experience with being a person with ASD. And he's preparing to have a child of his own with his wife. And so he thinks, well, the best way to do this is to observe other kids. And so he goes to a playground and sitting there with a notebook, is taking notes on other kids, right? Like, obviously we can't do that. And there were legal consequences. And then when he went to the police department, and the whole ASD thing was explained. Oh, that's an extreme example. But it actually has happened. I have had it happen with several people that I work with where there were consequences because something was really misunderstood when it was coming from a complete ASD misunderstanding. Self-understanding when older. Sometimes, if you're telling a young child who's 4, you have ASD, you're probably not going to get anywhere with that. Sometimes maybe, but not necessarily. But as kids get older, it can be really helpful to understand, okay, so why do I feel awkward when I'm going to that school dance? Like, why do I feel awkward when, like, my friend calls and maybe I don't want to pick up the phone? A lot of the kids will tell me, they'll respond to a text and then they sit there and have this awful feeling in their stomach, like, oh no, what did I say is wrong? So again, they're focusing on like, what's wrong? We could expand that to like, what's wrong with me? There's nothing wrong with you, right? Just neurodevelopmentally different. You have ASD, and here's some things that we can do to help you and work around it. For a lot of the adults I work with, the young adults and the older adults, I will say that one of the main reasons for doing testing as an adult and older adult was self-understanding, validation of past experiences, validation of why something was harder, and also the ability to share that understanding with family members, friends, and in many cases, and this is a newer thing, sharing it with potential and current employers. That can be a scary thing to do. But when we're kind of talking about interventions and things needed in life, that definitely falls under college/career period. And that's definitely something I'm doing with my older adults. And the last one would be compassion and understanding by others. So sometimes things will happen. Again, it's usually at school, and people are viewing them as if it was behavioral or conduct. And all of a sudden, when they learn, oh, if this was a person with ASD, then the compassion comes out. Do I agree we're only compassionate when there's a label? Of course not. But it's really awful to watch someone being berated for something that they did it's just part of ASD, and someone thinks they've done something behaviorally. So I feel like that added compassion can really make a difference for a child in school who's really struggling. All right, who commonly diagnoses ASD? Obviously, I do. Lots of licensed clinical psychologists do. Psychiatrists will. I've actually had some really amazing pediatricians who are able to do this too. The one thing I wanted to talk about, though, is there's a difference between school testing you to learn if you qualify for special ed services and a psychologist or psychiatrist testing you to learn if you actually meet criteria for ASD. So the difference is that when we're testing you, when a doctor's testing you, we're just looking to see if you meet criteria, not necessarily looking at the functional impact. We're taking criteria A, criteria B, checking boxes, doing tests. Do you meet criteria? Yes, you meet criteria. When school's doing their testing, school is more concerned with functional impact. If there's no functional impact, it's hard to argue that you need services for it. So a lot of times people come in and they're like, I don't understand. Why does school also need to do testing? School often needs to do their own testing because, again, they're looking for functional impact. Have I had schools who just take my report and use it? Yes, people do all kinds of different things, usually the private ones. Generally, when I'm working with a public school, it's usually they're also required. It's not that they're not valuing the outside report, but they're legally required to do their own testing because they're establishing eligibility for special education services. At the school level, it's usually the school psychologist that would be doing that testing. All right. I wanted to talk just a little bit about assessments at different ages. If you've got a very young child, it's going to be more things like playing and interacting with the examiner, parents filling out forms, getting information from teachers. If they're in preschool, someone doing a school evaluation, looking at things like adaptive functioning, right? What the child does, not what you think they're capable of, but what they're actually doing. When we're talking about school age, then we're also going to need to add, the intellectual and the language pieces in there, right? To determine whether it's with or without intellectual impairment, with or without language impairment. We're also going to start doing things like their ability to recognize affect on someone's face. We're going to look at theory of mind, their ability to recognize someone else thinks or feels differently about something. School observation can be helpful. We're also going to start looking at things like their awareness of social language, nonverbal social skills, a lot of tests involving pragmatics. And then what you're going to start to see, not so much when a child is very young, we don't really need accommodations. It's more what treatments do we need? Do we need an OT? Do we need a speech language therapist? When we're talking about school, yes, there's still a need for interventions or treatments, but then you're going to start seeing accommodations come in. And accommodations is things like, a place to go and calm down when they're upset, or a friend maybe to walk them to class, or something, acknowledging sensory sensitivities, right? The ability to have certain materials with them, maybe extra time on a test because they get distracted by things going on in the room. So school age is where things that we call accommodations come into play. As a young adult, you're going to see a blend of things, at least the way I do it, to recognize something. Older teen, young adult, there's things that are for up to 18. There's things that are over 18. When I'm testing someone that's 17, I feel like they're on the cusp. I actually pull from both of them because I want information from the parents and teachers, but I also want that person's individual experience. They're old enough to tell me, like, what is it like to go to school every day and try to be social? So I do sort of a blend. And then as we're crossing over into adult, it's more like the social cognition tests. I pull a whole lot of stuff from the Autism Research Center in UK. They're a little bit ahead of us here in the US. Check out their website. It's wonderful. The Autism Research Center in the UK. It's Dr. Baron Cohen. And then with adults, I'm also looking a lot of measures, looking at empathy, friendships. Do you go out with other people after work? What are your relationships like? And again, accommodations. Accommodations aren't just for up to 12th grade. Accommodations are also for college. Accommodations are for, LSAT, MCAT. Do you not need a college roommate because you have sensory sensitivities? All that kind of stuff. And again, with the adult, I'm really looking at the adult's individual experience. Sometimes they'll pull in friends or a partner to help contribute to that. And then overall, what I'm looking at is functional impact, which I know I said that's what school looks at. But for me, when I'm working with adults, there's no one at a school that's doing that. So I really need to look at that, especially because if I'm talking about accommodations, like lately, I've been doing a lot of accommodations requests for employment. And so it's really important. I have to demonstrate the functional impact to request the accommodations request. Okay, let's jump over to typical presentations. And we're going to go a little bit faster at the end here. Typical presentations of ASD, because we already talked about a lot of this. Rigid routines, restricted topics of conversations, poor eye contact, people talking about trains and dinosaurs, extreme need for predictability, dress unusual, super advanced vocabulary, talk like a professor, can appear emotionally immature. And keep in mind, you're like, this is not me. Remember, this is typical presentation. Explosive behaviors, some difficulties with empathy, unusual or absence of facial expression, difficulty with conversations, interactions, difficulty with group situations, sharing. Okay, so with that in mind, let's jump over into atypical. There are obviously more than 3 atypical ASD presentations. With the individuals I work with, these are the 3 most common ones that I work with. The first is gifted people, often do not have a typical ASD presentation. The second is individuals who were assigned female at birth, often do not have a typical ASD presentation. And the last is PDA, which stands for pathological demand avoidance, which if you want to check it out, go to the PDA North America website. It's a fabulous website, UK based, and you can look up PDA, which is a subtype of autism that we don't really recognize here in the US. Some of us do, but it definitely has an atypical presentation. So let's take a look at these. All right, gifted individuals. Language is often not delayed. They often have an advanced vocabulary, yes. They often actually can dish out sarcasm, which really throws people, but they can't necessarily receive it. They can have a really high ability, but when combined with being a little inept socially, they get misdiagnosed as just being arrogant. I see that one a lot. High achievement. Schools have a tendency to focus on achievement. If you're achieving, everything's fine, and not necessarily looking at the social emotional immaturity that can be missed. They often participate in things like chess club, D&D club, dance classes, things where there's a prescribed routine for how to do it, and people mistake that as everything is fine socially. They often rise above social drama. They're not interested in it, so people just assume they're really mature, when often the reason they're not doing that is it doesn't even make sense. They don't I have a lot of the teens I work with tell me that. They're like, I don't even get it. Often restricted interests are things that are socially acceptable to everyone else. A lot of times the things that they'll hyper focus on are not unusual. They're not obsessed with dinosaurs at 13. It might be a particular video game that everyone else is obsessed with, so you don't notice the special interest as much. Some of the treatment things that are a little bit different with gifted, and this is what those of us who work with gifted a lot have noticed. ABA does not always work with gifted. Social thinking groups often don't work because of the difference in ability. And you really need to provide skills and strategies for attending appropriate level classes. So if you have a gifted child who needs to be academically advanced in school with kids that are older, you need to make sure you're targeting your social skills interventions for being in that specific environment, not what they would need if they were with age peers in the younger classroom. And they may need assistance in communicating with school. right? Because everyone assumes, oh, like they're gifted, they can do all these things and use their own words, but they still need help communicating their needs to school. Okay. Let's jump over here. So people assigned female at birth. There's a whole lot of information on this now. It's definitely a hot topic. You can pop onto, there's some amazing TED Talks, people who were assigned female at birth talking about how they have ASD and it was just missed. So there's a lot of really cool research to look at with this. So autism in these folks, it can be a much subtler presentation. I feel like one of the huge reasons is people that are assigned female at birth are socialized differently. Better eye contact, social smiling, there's more social motivation. They copy other people's behaviors more. They'll copy other people's language more, copy the way they dress. They mask more, so get bullied less. Less likely to exhibit repetitive behaviors, more verbal, more socially interactive. Their interests can be more culturally acceptable, so less ostracizing. They actually use more nonverbal gestures. They often present with better imaginative play and actually exhibited a better ability to avoid inappropriate comments. Again, I feel like it's socialization. Like, unfortunately, people assigned female at birth are still socialized to be more quiet and blend into the background. And so if you're not saying so much, there's really less of a chance to make an awkward comment. They often kind of dress sort of weird. That is a way to kind of pick up. There can be a lack of usual hygiene focus. So for me, that's one of the things I'm looking at. And they often get a reputation for being sort of like having attitude mean problems, and that's not it. It's because they're not understanding what's going on socially. They often have groups of friends, but they'll be a fringe person. So no one notices, oh, you know, they have plenty of friends, but they're sort of on the fringe, and the core girls are in the middle. They sort of can memorize social behaviors, which helps with social manipulation. A lot of times when we talked about, sometimes you can blend up until the point where you can't, right? When the social stuff really kicks in, middle school, end of middle school, beginning of high school. A lot of times where we start to see the problems, it happens to coordinate with the onset of the period. So that gets blamed, and so they get missed for ASD. Picky eating in people assigned female at birth, just like, oh, well, you know, girls and women are always picky eaters. And so, again, it gets missed. Disliking social events. And they're often, sometimes they're more, again, socialized to be more introverted. So they're able to follow a little bit more, again, with all of the sort of copying. And then the high anxiety, the meltdowns. People regard a meltdown in someone assigned female at birth differently than they do in someone assigned male at birth. So treatment can be really different for people assigned female at birth. It can start later because we don't start until we know that it's there. Often it's starting with an actual diagnosis that was not given or mistaken for something else, right? The misdiagnoses that we talked about can be really common here. Most of the people that I'm diagnosing late life were assigned female at birth. And the treatment often requires, we're acknowledging sort of the trauma and the grief surrounding all of the things that happened as an ASD person, but not being recognized for that. It's kind of like, oh, it was a lot harder than it should have been. Okay, here's our last one. Here's our pathological demand avoidance. Again, it's a subtype of ASD, better known in the UK. You could think of this as an anxiety-driven need for control. Right? Anxiety goes up, but the more I can control things, my anxiety goes down. But what's really interesting about this is these are the kids where the reason they developed this subtype was these were kids where people were like, they seem ASD, but they don't seem ASD. They can appear social, but lack depth and understanding, excessive mood swings. They can be really comfortable in role play and pretend, which is definitely not what you would expect with a more typical presentation of ASD. They really restrict. They really resist and avoid demands and routines. When we all in our head think about ASD's love of routine, right, predictability, whereas they don't like that. They can be domineering, overbearing. They can be very bossy, right, need to kind of control the play because, again, that's how my anxiety goes down. A lot of times the obsessive behaviors that we see focus on people. See, again, there's a little bit more of a social flavor to it, whereas regular ASD, it might be more on like, you know, trains or a particular show or game. They often focus on people. I feel like a lot of my folks who are really into like K-pop obsessively over the years, a lot of them fell here. They're often more comfortable with adults than kids. They can be over familiar with adults. And one of the things that can mean is they can have difficulty recognizing hierarchy. And you can see how that doesn't work with authority figures in school at all. The other thing I want to mention, they can behave very differently in school as opposed to home. That comes up a lot because generally when we're talking about ASD, we're like, well, it should kind of be consistent. And I'll get, oh no, this is totally, child is totally different at school than at home. They kind of have this social persona they're putting out there, and then we're getting something different at home. Okay, so challenges and interventions across the lifespan. So what I really want to stress is just two things with this one. And this is our last one, and then we're going to jump into questions. So there's different things, there's different sort of transition points in life when you have to do something different. Entering school is huge, right? All of a sudden you've got to deal with teachers, other kids, smells, sounds, schedules, routines that maybe aren't yours, right? That's an influx of social into a child's life entering school. Middle school, it completely changes. All of a sudden they're juggling 6 different teachers. There's clubs at lunch, there's band in the morning, there's clubs after school. You know, we start seeing kids actually doing things without an adult with them. Like maybe they're going to, you know, being dropped off at a movie and picked up after a movie. High school, we've got, again, all the different teachers planning for the future. We see dating on the horizon. Most of the time in high school, they're interacting with other people their age, not with adult in the room. There's all the online content. There's the social media. We can do entire talks on social media, right? There's a whole lot going on with high school. Entering adulthood, whether it's going into a career, whether it's going into college, this is a huge time of change. And someone with ASD can look a lot different than someone without it and need a lot different supports. And then with older adults, I work with a lot of older adults. And what I see are some differences in terms of grandkids, parenting adult kids, dealing with retirement, dealing with a lot of the aging issues that go on as our bodies age as older adults. I feel like the sensory stuff really comes into play, and we need to acknowledge that. So depending on which stage of life the person's in, we're also going to look at what's the environmental fit at that particular time. You might have a child in a great school fit, or someone who works for an employer that's a great fit, and all of a sudden next year that changes and everything blows apart. We have to fix it again. What are the available supports? What's available? Are there services through school? Are there services through regional center? What's available for an adult? Are there different things in the community? Are there things through a psychologist that offers groups for ASD? There's a whole lot of stuff out there that didn't used to be there before. But again, you want to find out what's available for your area. It's wonderful that we have so many virtual choices now. It's a huge help. The big thing, take a look at the last one, needs and wants, right? Okay, so obviously if someone's 4, as parents, we're kind of guiding what they need and what they want. But for someone who's older, okay, what do they need and want? You know, do they want a really good best friend? Do they want to meet someone through interest? Do they want a group of friends? Do they want to go to a big school? Do they want to go to a small school? So it's not so much as guessing as someone ages, okay, this is what I think you need. It's talking to them. Like, what do you need? What do you want? You know, what are your goals in life? How can I help? You know, like I was recently talking with someone who's an adult, and we open up with, what are the social goals? What would you like? Some of my adults want to meet more people. Some of my adults want to meet an intimate partner. There's all different things. Some people want to make a career change. So what do you need and want? How can I help you? All important things to consider. Okay. So I did warn you guys, we were going to be all over the place. I wanted to give you little bits of everything today to kind of give you an idea of all the different things that I'm considering when I'm testing individuals for ASD and when I'm working with individuals with ASD. Okay, so here's our cool slide I promised I would show you. If you take a look at the bottom right, you can see it's showing you exactly what's on the bottom of your screen. So if you see that bright red telephone that you would click if you wanted to hang up on me, if you go to the right of it, there's some icons. And you can see the 4th icon, it's a triangle with a square and a circle on the bottom. And if you click on that, it then pops open the Q&A where you can type your questions into the Q&A. I've also put Summit Center's email if you want to contact us to schedule a consultation. Okay. All right, Elizabeth, am I good if I just jump in and start doing?
Yes, there's a number of questions under the Q&A. Okay, some have votes.
Let me jump in. All right, so we will go through as many as we can. Okay, let's see. Yes. Oh, Charlie, I'm sorry for the small font. Yes, DMDD is disruptive mood dysregulation disorder. If you actually, if you just type DMDD into your browser, it'll pop it up. There's some information out there on it now. Okay. And oh, great question, Jenny. Nonverbal learning disorder. So believe it or not, nonverbal learning disorder is not an actual diagnosis. It's not something we diagnose, but yes, you're correct. It falls under the umbrella of ASD. And there's all kinds of different parts of it. And so that's kind of what I was getting at when I was explaining, you know, anytime that I'm evaluating someone with ASD, I want to make sure I'm checking all kinds of things. I'm looking at visual processing, auditory processing. I'm looking at visual motor integration, fine motor. Because yeah, you're right. There's a whole umbrella of things that are under ASD, but there's not actually a nonverbal learning disorder diagnosis. Yeah, great questions. Let's see, when working with someone who has PDA profile, how can you determine if an increase in behavioral challenges is? Yes, it's an excellent question. And I don't know if this was before or after we had kind of talked about it. So yeah, you're correct. So as someone with ASD gets older, you see more behaviors that look like ODD. But if it's a PDA profile, how can you determine if it's just they're getting more PDA, if there's also something else going on? It's just a good evaluation. So for me, what I would want to look at, okay, so is there an increase in these behaviors? Are there challenges going on that would cause them to be more behavioral contact related, or is there depression? So the first thing that I would do is do an emotional evaluation and look at anxiety, depression, self-concept, self-esteem, what's going on, talk to the person. Often they can actually tell you what's going on. It's not necessarily that if you're PDA, you're going to all of a sudden like grow exponentially, become more PDA every year. But the presentation can change. Remember, I was talking about it might depend on like what's going on in your environment. Like if you have a better fit one year and the next year it's not such a good fit, we're going to see those behaviors go up and down. Yeah, great questions. Is it important for a child to get an official medical diagnosis? Okay. Mary, yeah, great question. All great questions. So here's the thing. It also kind of depends on the level of functioning. So because of regional center. So for someone that's school age, well, prior to 3, regional center covers you. Once you're 3, your local school district covers you, even if you don't attend public school. Once you're over 18, you're back to regional center. So if you don't have a diagnosis, can you then get one and get services through regional center as an adult? Yes, you can. I actually called regional center and asked this question, talked to a lovely person. However, it's harder. She said it's much easier if you have had a relationship with regional center prior to then enter regional center, and or if you have an earlier diagnosis and you've had a relationship through your local school district to then enter regional center. It's harder to not have a diagnosis, not have had anything going on in terms of intervention, and then try to enter regional center. Is it impossible? She said, no, it's definitely not impossible, but it might be a little bit more work. In terms of the medical diagnosis entering college, we were talking about accommodations. I do ask for accommodations for folks with ASD. One of the things I often ask for, remember we talked about all the sensory stuff, anxiety. So for a lot of people, sharing a room brings all that out. A lot of my folks that have really extreme sensory sensitivities, really particular routines, behaviors, some things that almost look OCD, like can't tolerate a roommate that's going to be really messy, I'll often request a solo room, and you need a reason you're doing that. And an ASD diagnosis is one of the reasons they allow me to do that. So you can't just go in and request accommodations, be like, well, I think I'm on the spectrum. You have to actually have proof. Yeah, they tell you what to attach, medical diagnoses, reports, whatnot. Yeah, great questions, everyone. Another awesome question. So someone's curious if I'm seeing more gender dysphoria or gender identity issues with ASD kids. Yes, a resounding yes. So when I was talking about why I chose those 3 atypical presentations, assigned female at birth, gifted, and PDA, remember I chose them because that's what I see the most of. So I have, and there's also overlap, believe it or not, with gifted. So a lot of folks that I work with are gifted and have ASD and are part of the LGBTQIA+ population. Yeah. Okay. Co-occurring diagnosis where it's challenging. Oh, written response. Okay, got it. So someone's asking for the difference between dysgraphia and dyspraxia. So dysgraphia, you could think of it as the writing version of dyslexia. It's like we have reading disorders. It's a disorder of written expression. It's the one where you read the essay prompt and it's not like you could do a really good job if you were typing it. You would have trouble whether you were typing it or writing it, or maybe even telling me, but telling me would probably be easier than writing or typing. Whereas dyspraxia, you may be able to respond fine if you're typing, but you can't handwrite. Yeah, so you want to look up, it's specific learning disorder with impairment in written expression, and a lot of us shorten it to dysgraphia. Click off that one. Oh, common treatments for APD. That's an excellent question. There are no common treatments for APD because your treatment should be customized. So there are different types of auditory processing disorders. You want to go to an actual audiologist. Well, I can screen for it. If you come up positive on the screening, which takes me 20 minutes, I then send you to an excellent audiologist, of which I refer to in the area. So depending on what you have, so some of the things I've seen as treatments for APD are cap dots, BAT, LACE. They're just some of the ones that pop into my head that the two audiologists I use. Yeah, so it should be customized depending on your type of auditory processing disorder. Do I happen to know if there exists any resource or graphic detailing the presentation of ASD at different ages, stages? I'm not that I'm aware of, Jen. That would be really cool. I'd love to see it. Yeah, I have not seen a graphic detailing it. Doesn't mean it doesn't exist, but I've not seen it. I would love that. Oh, Christy, excellent question. So you received a diagnosis from Summit at age 7. Does he need to come back? Check with your school district. Some schools want things redone every 3 years. Sometimes they want it redone entering middle school. Sometimes, and you want to time that too. Like one of the high schools I work with wants testing within 3 years. So I didn't want someone to redo their testing in 5th grade and then have to redo it again in 9th. So we were trying to kind of get it within. So sometimes, yeah, you look up the school district, look at your middle school and look at your high school, see what their requirements are for testing. In terms of college, not all colleges require you to retest. A lot of colleges are like, if you had accommodations in high school, they take it and run with it. There are a handful that want retesting. I want to say USC and Notre Dame recently both wanted retesting from people that I work with. Yeah, great questions. Intervention supports for kids diagnosed as being bipolar. Oh, Cheryl, that's a hard one. I currently do not have any kids that are diagnosed as bipolar. I don't see kids under 12 if you're talking about pediatric bipolar, but I love that you brought this up because one of the reasons that DMDD was created as a diagnosis was because they felt it better captured the behaviors of pediatric bipolar. So you might want to check out DMDD. Because I'm not as up on pediatric bipolar. But yeah, you're right. A lot of kids get misdiagnosed as bipolar when it's ASD. Okay, let's see. Neuroqueer part of neurodiversity, could it relate to ASD? Isabel, I'm not sure if I already answered this one, but yes, there's a big overlap. A lot of folks that I work with are part of the LGBTQIA plus population and also ASD. Yeah, there's a huge overlap there. Emily, theory of mind. Oh, Emily, great question. Yeah, NEPSI is cool, but higher functioning kids will ace the NEPSI. Take a look, go to a website that's called Theory of Mind. Look at the Theory of Mind inventory. It's parents and teachers complete it. The adult can complete it themselves for, I think, age 18 or 19 plus. But there's also a Theory of Mind task battery. It's not super challenging, but I find it actually picks up more than the NEPSI Theory of Mind with cognitively advanced kids. Okay, let's see. Another great question. After diagnosis, is there a hierarchy of priorities? Yes, there is. So for example, when I'm doing a report, I'm giving all the diagnoses, I always have a post-evaluation consultation with either the adult, if it's an adult evaluation, or at the parents, if it's a child, or at the teen, if it's a teen, and then with the parents, whatever's needed. When we go through them, that always comes up is, we call it next steps, like what's our plan? because it depends. Generally, we're going with what's the most problematic or presenting. But like the one I did yesterday, there's a deadline at school. So we're going with what's needed for a deadline at school. So everybody's different. But yeah, it's definitely something we always discussed in the post-evaluation consultation. Okay. Elizabeth, I'm not sure how many are left in here. I was going to try to squeak through a few more.
I
Okay.
would do a couple more and then
we'll have to cut. Everyone, your questions are wonderful. It's obviously a very savvy audience. Barbara, have you seen increased incidence of ASD with Ehlers-Danlos? Yes, definitely. As to whether or not it's more with assigned female at birth, in general, I have more EDS that are female, but I do have assigned male at birth that are EDS, but there's definitely increased incidence of ASD. Yeah, I don't know if there is research on that or if that's just coming out of those of us that work with the ASD population seeing it. Oh, but I should also specify, but I also specialize in gifted individuals, and there's a huge overlap with EDS and gifted. Okay, and okay. Oh, Don, excellent question. Oh, I'm so sorry it wasn't until you were 62. Thank you for sharing that with us. Yes, there are lots of people that do this kind of stuff. I honestly, if I click the little inquiry button down there for Summit Center, or if it's really hard to see, you can just call Summit Center, look up Summit Center online. We have lots of people at Summit Center that work with adults with diagnoses of ASD, GAD, PTSD. If we're full, most of us who do this know other people that we can also make suggestions. Thank you for that question. And okay, this is like Elizabeth telling us it's being recorded. Elizabeth, this question's for you. Jenny wants to know if the $20 fee allow for lifetime access. That's a you question.
Yeah, yes. Once we add the fee on, it'll be for lifetime. Okay. As long as that platform exists. Yes.
Thank you to Elizabeth. Oh, there we go. So you put it in writing. Awesome. Differences with ASD in girls as opposed to boys. I did. Thank you for your question, Scarlett. I did cover some of that. I don't know if the question was before. Actually, I think it was after we did that. We did kind of go into that a little bit, but I feel like overwhelmingly, Scarlett, I feel like one of the main differences comes from socialization. Like, I know we all like to think that everything is, equal now, but it's not. People assigned female at birth are still socialized differently. They're even socialized differently in the classroom in terms of behaviors that teachers will tolerate. And so I feel like that can be a huge difference in terms of what we see with behaviors. If you're asking about, are there just, specific innate differences? I guess we could, possibly argue that there are. I really feel like it's more socialization and expectation. Great question. And Charlie, is DMDD depression? Yes. Yes, DMDD is a childhood depressive disorder. And PDA and communication challenges. Oh my gosh, that's a huge question. Anonymous, thank you for your question. I would recommend going to the PDA North America website because there's so much there. They also have a list of books. They also, believe it or not, have those of us who all just attended the conference there. They've made some of the recordings from that conference available. I think there were 6 of them, which is a really wonderful resource for everyone to be able to watch some of those. So with PDA with communication challenges, with the folks that I work with therapeutically, some of the big ones I see is you can't communicate if you're completely in the middle of a sensory overload meltdown. That's huge. Another one can be if you're trying to communicate with someone, you can come off sounding sort of bossy and controlling. Again, that's coming from a place of anxiety. Those are the 2 biggest ones that pop into my head just because of who I work with. But I would suggest checking out that website and watching some of those videos. They also have different sessions you can participate in every month. It's really wonderful. Okay, we click yes. Okay, let's see. All right, I'm going to take this one last one, and then sadly, that's all we have time for. Pauline, how long is the diagnosis? Is it normal to get reevaluated every few years? I'm assuming you're meaning how long does it take to get it? It will depend on the year, how old you are. So if I'm diagnosing someone who's 4, it doesn't usually take that long. I mean, we're usually doing it over maybe 2 or 3 days, spread a week apart or something, because there's not a whole lot we're doing. I mean, part of it is we're if they're old enough, I'm testing intellectual ability, because we have to determine whether it's with or without, intellectual disability. I might be checking language if they're old enough to check language. So it really depends on what I'm looking for. If it's someone who is in middle school, high school, we're sort of looking at the nonverbals and the affects. And if they've had prior cognitive abilities and prior achievement done, we don't need to do that part. If they've had auditory processing, visual processing done elsewhere, I don't need to do that part. So it really depends on what are the presenting areas? Has anything else been done anywhere else? Because keep in mind, if you come in with, diagnoses from other places, like someone picked up on part, but not the ASD, we already have that, and I don't need to test for that part. So they really can vary from, something that would maybe take just like 3-4 hours with a very young child, to some of the really comprehensive ones I've done with teens and young adults, where we're looking at everything across the board. It can take as much as 14 total hours, which would be spread out over weeks and months. Okay. All right. I think that's all we have time for. I just want to thank everyone. All of your questions were wonderful. I'm so sorry we didn't have time to get to more. We could literally sit here all day and talk about ASD, which is what I do every day. Thank you so much for joining us. Thank you for the thoughtful questions. And you know where to find us if you need us. Thanks, everybody.